Good morning, everybody. Please have a seat.
Okay, buongiorno, good morning everyone. Thank you to be here. This is one of the, please take a seat. This is one of the greatest SICSSO sessions because we have a super panel of experts, but also we have surgeons around Italy and here performing surgery and teaching us how to do different type of surgery. So just to follow the program, we have a DALC first, then some very special surgery from here, but remotely controlled with patients elsewhere, and finally a DMEC. So we cover almost everything in terms of corneal surgery. The first surgery will be from Catanzaro, and will be Professor Scorcia, which is director of the University Hospital there. He's an ordinary professor, and he's a super expert of DALC. I am going to briefly introduce the case that is presented, which is a keratoconus case. So if we could have the slide on the screen. And the surgery is live, but remotely projected from Catanzaro. So, it's a patient with keratoconus. We've got a 21-year-old female. She had cross-linking in one eye, so likely no need for surgery in that eye, because with a minor prescription, she's doing extremely well. The other eye has corneal ectasia, advanced keratoconus, and poor best-corrected visual acuity. And this is topography. You can see the posterior and anterior float, the corneal thickness well below 350 micron, the thinnest point. And there appears to be a tiny little bit of scarring, but Vincenzo has explained that there is been no eye drops. So this is for a big bubble DALC. So if we can now, and that's the photograph of the patient, you can see the box 3i and a little bit of scarring, which is typically the apex of the keratoconus. So for this patient, Professor Scorcia will perform a deep anterior lamellar keratoplasty with his own version of the big bubble technique. So can we please start the connection with Catanzaro?
Good morning, can you hear me?
Yes, Vincenzo, we can hear loud and clear. Okay. Thank you, first of all.
Thank you to all of you, and I would like to thank you, Sir Nicola, for the kind invitation, and also you for the nice presentation. So I think you already said something of the patients. As you can see, there is a little scar down here, and the planning will be to perform a DALC. Usually in this case we start with big bubble technique, and in case of failure we move to the peeling off technique. So the cornea is quite large, so I can show you this is 9. And I think it fit quite well. Usually we do DALC as large as possible, so the range of our definition may vary from 8.5 to 9. So this is our standard. So the first step is to obtain the geometric center of the cornea. So I take mesuration limbus to limbus.
And which kind of anesthesia are you using, Vincenzo?
In all cases, peribulbar anesthesia with narrowband 10% and hyaluronidase, in all cases. Unless the patient is very, very young, usually if they are younger than 18, I prefer general anesthesia. So the first trick to improve our success rate is to obtain very deep trephination. I think you already showed the map, the pachymeter map. So in the periphery we have almost 600 microns. So in this case we aim to go deep up to 500 microns. So the first step is to align the blade. So you can see now it's aligned. So I make 2 taps down to improve suction of the trephine.
And which trephine are you using, just for the audience? I can see that, but...
It's a Baron trephine. Okay, the suction is on. So the first 2 are neutral. So now it starts to cut. Now I did 4, 5, 6, 7, and I go slowly, just in case. Okay.
And the diameter of your trephine, Vincenzo, was?
9.
Okay, so it's very large.
9, yeah, very large, yeah. As you can see, even if I've done 9, it's not so big because the cornea is very, very large.
It's beautifully centered.
Yes. I always dilate the pupil because I use the red reflex coming from the back to guide me to obtain a very deep dissection. Okay, as you can see, I have a very deep definition here.
Yeah, it's centered beautifully. It's really good and deep. So
I do a small pocket to introduce my spatula. In some cases I perforate, but even if I perforate, it may serve as a reference. And in this case, I move aside to have a different pocket.
And the spatula that you're using is the...
It's made by Yanak. Okay. Now I use the reference, the small fold in front of the spatula to judge the depth of my dissection. As you can see, it's rather depth. It's not so depth in this case, but there is not too much resistance. I try to make it just a bit longer. There is some resistance. I'm not sure that I'm really that deep. I don't like it. Okay. Vincenzo, I don't know if you saw the folds. In this case, I'm not happy because they are too superficial. So in this case, I prefer to do another attempt just to be deeper. I like to spend more time in this phase instead of facing with a failure. much better here.
Yeah, seems to go much.
Yeah.
Really. And this other instrument you're using is still made by, or is it just a needle?
This is just the spatula, okay? And now I move from to the cannula, okay? I don't like to push air very straight because I don't believe that what really works is the straight, but is the depth of this section, okay?
But we can see that it's going really smooth.
Yeah.
Through. That's it. Perfect.
Okay. Now, if you see the bubble does not reach the edge of the definition. In this case, I tried to do a paracentesis in order to decrease the pressure in the anterior chamber and to facilitate the expansion of the bubble. Okay, but remember, I did a 9, so it's not so easy to enlarge the bubble up to 9. So in this case, I just inflate a bit more and I stop it because I don't want to break the bubble, right?
Yeah, it looks absolutely perfect. We could see the bubble expanding as projected more, so that's beautiful.
Okay, the next step is the keratectomy. So I remove most of the anterior stroma in order to facilitate the next step of the surgery when I have to open the bubble. I don't know if you have any question, Vincenzo, now, because it's quite... yes. Please tell me if I'm not very centered, because...
I think, I assume the cannula that you were using was the Cernicola cannula, or a different one?
The spatula is San Nicola spatula, yeah.
So he's using some Cernicola stuff.
Yes, and I also took from him the peeling off technique. I remember once I was doing a light surgery, and he suggested me to stop to do visco dissection technique and to move to peeling off technique. And from there I started to do it, and I think now it is my preferred surgical technique. I also told him once. I think he can say it, really.
Any comment, Vincenzo?
So today we are here, 3 Vincenzo.
Yeah.
And you know that Vincenzo means that you win. And you are winning. You are doing a fantastic surgery and really very teaching approach. So the audience here is full, and they are enjoying your teaching.
Yeah, I think I'm very happy to it, even also for you, for sure. But I think the main goal of this surgery is not to obtain a very nice bubble like this case, but is to perform DALK in all cases. So I think you have to, in all cases, you have to have escape way, okay, in order to perform DALK in all cases. I think this is the trigger. What do you think?
Yeah, I agree with you 100% because the survival of the graft is completely different if you compare the graft of a DALK with a PK graft. And the key point should be that we don't have to exchange the endothelium. I just want to add a few words about the extension of the bubble. The maneuver, when you make a paracentesis to enlarge the bubble, in my hand I had 2 cases that the bubble opened. And so I prefer to dissect the peripheric part slowly with the spatula, or just pushing the tissue, and in this way I feel much more comfortable. But I really appreciated your approach that make the bubble larger.
Yes, you're right. You can run the risk of perforate the bubble. Usually, I prefer to point the blade toward the iris in order to reduce the risk of touching the bubble.
Yeah.
Good morning. What a beautiful dissection this is so far. It's Catherine Colby from the United States. I really enjoyed that you took the time to do a second entry because you weren't happy with the first one. I think that's very important, and sometimes surgeons are so anxious to get on with the case that they don't take the time to do that. I think the thing I'm thinking about as I'm watching how easy and beautiful this is why are surgeons in the United States not doing it? We just received the EBAA statistics, the Eye Bank Association of America, for 2024, and we did about 700 DALKs in the US last year. So we have not adopted that technology.
Hi Vincenzo, it's Diego.
Hi Diego, good morning.
Good morning, congratulations for your very clean, fantastic surgery. I have a question. DICE now it has how many? 20 years. We are doing DICE since 20 years or more, something like that. Do you have any feeling about the rate of recurrence or presentation again of keratoconus in the host after DICE, if compared with the penetrating keratoplasty? Because a number, some cases of penetrating keratoplasty do indeed recur.
Yeah, you're right, Diego. I think the recurrence rate will be different only if you change the size of the graft. Because if you do an 8 millimeter DALK, you probably change the same amount of tissue of you usually do with decay. So in this case, we don't be afraid of endothelial rejection. So I think we have to do the DALK as large as possible. Okay. So if you do 9, you change all the tissue. So probably in this way you can reduce the risk of the recurrence of the ectasia, because we remove also all the peripheral tissue. So for this reason, this is our standard. I never do a 8 millimeter DALK. There is no reason to do it.
Yeah, I totally agree with you. And in fact, I think that another advantage besides the endothelial advantage of DICE is the possibility to enlarge the diameter to quite an extent. Thank you.
That's beautiful surgery, Vincenzo. I think having the luck of working in an eye hospital with probably the largest dedicated eye casualty in Europe, certainly, and beyond that, I think one thing that really worries me, and one reason for me to do DALK, even when there is a scar, at the cost of reducing the vision, is trauma. Because we see so many patients coming with trivial trauma, and the PKP just opens up, they lose the lens, they get deepest bleeding, and the eye is basically not lost, but close to it. So with DALK, this is much less likely to happen. That's why I always think it's better to sacrifice 2-3 lines of vision in the presence of a scar and do a DALK anyway, with perhaps not with the big bubble technique, of course, but with the peeling technique that we were describing before, which works really well in predescemetic DALK, like Vincenzo, Sarnikova, and Rajesh Fogla, and others have shown to us. I think you're going to be faster than the time that you have. This is unbelievable, super efficient surgery.
Hello, Vincenzo. Here is Nicholas from Brazil, and congratulations for your beautiful surgery. I really like the way you going through with your cannula, seeing the strias and the decimae, that really helps to see if you're in the correct plane. Just not just feeling that it's easy to put in the cannula, but watching the stria really gives you another mark to see you're in correct plane. And it's a beautiful surgery, congrats. And I have a question. If you have a patient with a previous hydrops scar, would you still go with the bubble technique, or would you change for a peeling off or another manual technique?
Yeah, it depends. If there is a huge scar, I will prefer to do a mushroom PK. In all other cases, I start with iron injection, but I put the cannula very superficial just to obtain the corneal emphysema, and after that I proceed with the peeling off technique. And probably Sir Nicola may confirm it, the results may be very, very excellent, even in case of eye drops. Because even if a small opacity remain in place, usually it does not affect the final vision. So it's much better to obtain a very dark, even with a small opacity, because the vision could be very, very good.
Great, thank you.
Hi Vincenzo, this is Jose from Barcelona. I don't want to disturb too much you because you're on the periphery, but because you're on the periphery, my question is that you have not decided to go and dissect underneath the extension of your original gas air bubble. Do you regularly do it that way because you want to avoid any risk of perforation during this extra dissection at the periphery?
Yes, there are different ways to do it. For example, the Bossier school prefers to leave a peripheral ring of the tissue. I don't like it too much, so I prefer to remove as much tissue as I can. And if you saw, I put the scissor horizontally in order to reduce the risk of perforation. But even if you have any perforation, it is very peripheral, so it does not affect the final result of the surgery, because you can put a small bubble of air into your chamber, you can finish your surgery without converting in a perforating procedure. So I think the procedure is almost done, so you don't be afraid of small perforation in the periphery. It's my opinion. I don't know if it's the same of some of you.
No, of course. But my question was that you have not used the dissector to try to reach...
Sometimes I use it.
Okay.
It depends. Yeah. I can use it, but I have some perforation with the dissector, so...
Okay. That's exactly what I think.
Yeah.
Okay, I agree with your...
So I cut the donor to the same size of the recipient, and so 9. I like to stain the Descemet just to improve the vision and to make you see the endothelium, because now I don't need the endothelium anymore, so I can remove it.
Vincenzo, I've got one other question for you, which is, how many dark have you done? Because perfection makes us perfect. The surgery is perfect, and we need to know that, because...
Wow, this is a good question. I don't think it's not really important how many you've done, but how you've done. Okay, so you can, it's what I say every day to my residents, because they are really convinced that if you do a lot of surgery, they become very good at surgery. No. I think you have to change your mind and to really realize what they are doing. So in this way you can improve your surgery. So even if you do only one surgery, I think you can improve your results. But you have to understand what they are doing.
That's absolutely correct, but still, doing a doc in this way in 30 minutes, you must have done tons of them, and that's important to know, because we all know that surgery is about, thinking. The difference between a good and a bad surgeon is thinking, but also practice makes us perfect. So undoubtedly, having someone like you that teaches how to do doc properly is an unbelievable thing. But you have not answered my question.
I don't know really. Maybe Adriano or Andrea knows. How much? 2,000. 2,000, they suggest me.
That's
Yeah,
a number
probably.
that is unreachable by most corneal surgeons in general, because 2,000 dark is huge, so it's beautiful.
I think this is the problem with dark, because if you wanted to become good phagoemulsification, in your back you have a lot of patients. Instead, if you wanted to become a very good corneal surgeon, the number are not so big, so
Yeah.
you have to wait. So the learning curve may be quite long.
Yeah, it's really a question of health policy, because, for instance, in the UK, we are thinking about how many corneal surgeons do we need, because otherwise you end up with lots, but not very good, or you can have few, but very, very good. So
I think 50 procedure could be enough number to achieve, to be quite confident with the technique. Okay.
I agree with Vincenzo. I think that, of course, you need a minimum. You cannot, as it was a little bit exaggerated, just one, it will not work. But I agree with him. I think it's a question of training, of cases, but most important is a question of brain. And you need how to do things more than to repeat them 100 times in a bad manner. So.
always do that before your surgery.
And you can practice in wet labs too. It's not exactly the same, but you can practice in wet labs. And knowing all the techniques, you know, when
and
we
again,
started back
S.I.C.S.S.O has
there.
been leading here because there have been so many wet labs this year, even with less people, so more concentrated, dedicated to this type of surgery.
And getting all the information from those courses, those congresses, all that helps too.
So we may even be able to follow all your suturing through, but we've got only 5 minutes left. So tell us about your suturing technique. Vincenzo,
Yeah.
tell us
that's
about
good.
your suturing technique then.
Okay, now I'm putting the 4 cardinal stitches, and after that I put 2 16 bites running suture. This is my preferred surgical technique. I always prefer to put 2 still running suture, especially in young patients, because if one suture breaks, you have the other to prevent the opening of the wound. Usually the first one is removed in the first 6 months, and the second one 1 year after surgery. I put single stitches only in case of hepatic disease or peripheral neovascularization, because as you know, the risk of losing a suture is very, very high.
Vincenzo,
Yeah.
on behalf of the SICSSO and all the audience, what can we say? Just super, thank you. Beautiful surgery. We are super impressed.
Thank you to you.
And I'll come and visit you in Catanzaro because I feel my DALK is not up to scratch, having seen you operating the DALK under 30 minutes and you are almost finished, and it was beautiful. And thank you for all the insight in terms of the sizing of the grafting, like Professor Colby said, take your time in getting it right the first time, so change your approach if you are not happy, etc., etc. So I think you have exceeded all our expectation, and we just want to give you a round of applause for fantastic surgery.
You can change the theater now, and you come back in 20 minutes when I finish all my sutures, so you can check the final results of the surgery.
Absolutely.
Because now I think this is a boring part of the surgery.
The pressure is on for the next surgeon to be done in less than the dedicated time then. Thank you, Vincenzo. Bye for now.
Thank you to you.
Okay, now the next surgeon is Professor Alessio. Please come from Bari, that is going to do surgery from here. but on a patient in Bari. So actually, I think the best thing if I leave you to explain exactly what you're going to do for us. The podium, or if you need a microphone.
Yeah, keratoplasty is a wonderful surgery for the cornea, but we have not enough tissue for keratoplasty to everyone. And sometimes we can do something of different. That means that we can offer to the patient a faster recovery than keratoplasty using a laser regularization of the cornea associated to cross-linking. So that means the cross-linking plus. And now we are starting for a cross-linking plus by internet, by 5G, from here to my operative room in Bali. The patient is there and I am here. I am not to wash, to prepare, I can operate myself. So.
I think that sounds great. Well, that's all operating from home. Okay.
Okay. I am Dr. Mularoni, and I'm going to introduce the clinical cases that will be operated by Professor Alessio. The important thing is the surgeon is here and the patient is in Bari hospital. This is very innovative because we have a possibility to read the slide. The microphone. The innovation is the surgery with remotely controlled. What does it mean? Very advantages, I suppose, in our, but in general opinion, because the question, a simple question, it was started with a simple question. The question is, what if distance didn't matter in surgery? This is a very important idea. Because with this kind of technology, we can bring the high care in places where the specialists, the ophthalmologists, are not available. Second, no traveling, no long distances, no waiting for a long time for the patient, but the patient can have the best care where they live. And this is the innovative for the suite by high-risk company. We know, everyone knows that the high-risk company was the first company produces patent and model for custom ablation. The software is called SICSSO and is the first repeatable software for corneal customized ablation. You have to imagine that there is two big rooms. In the first, we can screen and follow up the patient, and in the second room, we perform the surgery and the treatment. Both these rooms are remotely controlled, and this is the innovation and the very important things. Today patient is a very challenging case, as Professor Alessio tell us, is a patient with advanced ectasia, a male of 26. You can see the refraction, plus 3.5 with the -9 of cylinder, pure uncorrected visual acuity, 20/28 best corrected visual acuity. This is the typical keratoconic ectasia in the inferior temporal area, with the ectatic bulging area more relevant on the posterior surface. The epithelial thinning, we know that is at the apex of the conus is thinner than in the other area, can reduce the stromal ectatic bulging. With the ray tracing map, we can really calculate the possible compensation of the epithelium, of the distribution of the epithelium that can correct achromatic compensation. With the ray tracing technique we can measure. In this case, the compensation is equal to 2.1 diopter. Also, there is a compensation by the posterior surface, especially about the chromatic aberration strongly induced by the anterior one. And in this case, with the ray tracing technique, we measure, and the value is the same that the epithelium compensation, 2.1. The aberration is reduced. There is also a tilt to compensate. When we have advanced ectasia, there is also an important tilting, and in this case is 1.1 prismatic diopter. At your right, you can see the distortion of the vision and the very bad quality of vision of this patient. This is the ablation map. The central point is the most important thing to know, to understand, because we have 85 microns of ablation to regularize, generally speaking, the corneal surface. And very important, we have just 2 millimeter zone. 2 millimeter zone, it's important to understand that is not the treated zone, but the zone we expected will be regularized. To maintain currency or other kind of problems due to high gradient. In this case, the stromal thickness gradient varies from 16 micron to 73, and is very important for the second phase of the treatment, the cross-linking, because also the cross-linking is customized. Where the gradient is higher, the energy will be higher. Where the gradient is low, the energy will be lower, and this is important for the final result. Okay. And this is the cross-linking map. The energy will vary from 2.85 joule square centimeter to 3.25 in the area of maximum bulging of this keratoconic patient. What we expect, there is the expected post-op anterior elevation, and this is the expect ray tracing. Especially we can notice the difference between the anterior and posterior cornea, because the posterior will compensate the anterior aberration. This is the final result with the simulation of quality of vision and corrective of the tilting. Okay, next step, technical details from the Giuseppe D'Ippolito.
Okay. I start.
Thank you.
Yeah.
Just a couple of information about what you will see. Professor Alessio here, with this basically remote control, will control the laser in body. What is very important is to control by 5G the latency, because we need to have a very short latency. This is very important. And basically, on top of the latency, what the surgeon is available here is a laptop, 3D laptop, where he can basically control the laser from here, a 3D monitor to visualize, and a joystick to stop the surgery, which will start right now. Thanks.
Okay, I take the control.
Perché ha fatto il joystick? Capendo? Vabbè, va bene.
Okay, the patient, yes. I control now the laser. Now the procedure is fully automatically. So the distance from the laser, the centering and some other is all automated. Wait at the cornea, please.
The system is making patient registration, bringing the pupil size to the same pupil size on the tomographer, and then basically controlling the infrared light. As soon as this will be completed, the surgery will start.
Okay, dry the cornea, please. Okay. I'm starting. The laser is started. Here can you see on the apex of the cornea is running.
The speed is extremely low now because it's working in a very delicate area. So the speeds go from 2 Hz up to 2000 Hz. And the speed increase to grant constant fluence per square millimeter in the cornea.
How long does the exam take?
It will take the treatment basically around 60 seconds, from 50 to 60 seconds. The whole treatment. Removing epithelium and stroma.
35 seconds remaining.
You clearly see the customized, it's of course reversed, but on the top right you can see the ablation.
And can you actually talk to the patient as well and tell them, please hold still, don't move, etc.?
Of course, the laser gives information, voice, it's voice driven, the patient is voice driven.
Now, we have to start with the inhibition with the riboflavin.
So just for a few quick information while the riboflavin soaking time will start. Can you just a few slides? So as I told you before,
carry on, but let's try to give us the information about riboflavin, and then we need to move on to the next.
Yeah, I will just give the information on the riboflavin and then we will stop. So can you go? So again, the laser 2 kHz system, it's designed to remove in one step epithelium and stroma. The 2 kHz is a patented technology, and to have a focused beam only of 350 micron. This is the concept I gave you. The laser does not only work at 2 kHz, but slowly and increase to constant fluence. You see that in order to prevent plumb, there is an arm which came down in order to control completely the flow. You see from there the air go in, and this will stabilize completely, basically, the plumb effect. And inside we have two basically optical paths, one for lasering and the second one for hardening the cornea, which is what we will do right now. And again, basically this is customized according to the energy for the 365 is customized according to the cross-linking and limited up to where we have the pathologic region of the cornea to minimize the invasiveness of the basically UV radiation. The UV radiation, which Professor Alessio will use SAFE-CROSS. This riboflavin is a specific riboflavin designed in order to minimize invasiveness, because this will irradiate only for 3 minutes at 18 milliwatt for 3.2 joule per square millimeter.
Excellent. Thank you very much. Thank you. I think what we should do, we ought to have a quick look at and say again thank you to Vincenzo Scorch as well before we go back to this case. So can we just connect with Catanzaro for 1 minute? Because then we are running late. We need to connect with Professor Ser Nicola, Clinica degli Occhi. I've operated there last year. He's very well organized, very friendly. So can we, Vincenzo, we have 1 minute to say thank you again and to see your beautiful suturing.
Yes, I almost finished the second suture, and after that I check the astigmatism and the suture will be done.
Fantastic. This was a perfect DALK, 9 millimeter in less than 1 hour. Thank you again, and
thank you to you.
We'll see you soon, hopefully. Thank you. Bye. Now, I think we'll move on to the Clinica Ser Nicola. No, it's you.
We have to wait 4 minutes.
4 minutes.
For the soaking time.
So I suggest what we do. We go to Clinical Ser Nicola and then we come back, or... Okay, let's go to Clinical Ser Nicola because so we can see at least what is going to happen there and they can present the clinical case. Right, it's about 4 minutes, is it? Yeah. So, Gianni.
Di Ser Nicola.
Adesso, ok, allora presentiamo prima il caso. Okay, so let's present the case of DMEC from Grosseto, and then we go back to the...
Hello, good morning. Can you hear us?
Yes, we can see you.
Good morning. So we have here Professor Pedrotti today perform a DMEC surgery in this patient. Can you move on with the slide, please? So this is a Fuchs dystrophy patient, and she did phaco surgery in 2023. In the past year, she has decreased vision and confluent central acuity. The visual acuity is 20/40 with pinhole. She becomes 20/20. So next slide, please. So this is the pre-op evaluation. You can see the endothelial microscopy and the anterior segment OCT. So the surgical plan today is DMEC, and we are going to use a preloaded tissue by the Venice Eye Bank. The donor age is 62 years old, and it's pre-punched at 8 millimeters. So we can move to the surgery.
Okay. We are trying to get 2 surgeries done at once, so that's not easy. But I suggest, why don't you show us the preparation graft that is preloaded? Yeah, they did say that this graft is preloaded from Diego Ponzin, that is here, Eye Bank. I have to say, I have no experience of preloaded graft, so then, can you tell us a little bit more? Are you still with us from Grosseto? Perhaps you can tell us something about the preloaded graft, Diego?
Well, this is one of the...
Veneto.
Please, go ahead.
Can you hear me?
Hello? Probably we lost the connection with the Clinica degli Occhi. Hoping that they are come back.
Yeah, we have less than 1 minute. 1 minute that they prepare, and then can start with just to see how and where is the cross-linking spot. It is customized and not regular. can do also a regular standard cross-linking. But in these cases, we prefer a customized cross-linking. Okay, I have 10 seconds if it's possible to see the image from body. Okay, now
Aspettiamo un attimo per la DMEC, se è possibile, si aspetti un attimo perché così concludiamo l'intervento che stiamo facendo di PRK, PTK, quindi dateci solo 3 minuti, giusto?
3 minuti?
Ok.
Sì, anche meno, oramai.
Sì, andate avanti voi, noi intanto mettiamo il pedino.
How can you see the spot of the energy? It is customized upon the thickness of the cornea and the thickness gradient.
L'asciugo
And is
Poi dopo segnalami
where is the apex of the focus? It's not central.
Certo, faccio io, guardi.
Allora, possiamo togliere un attimo Grosseto, il professore finisce rapidamente in 2 minuti e passiamo a Grosseto. Sì, la voce.
Now we are only to wait 2 minutes of irradiation, then we medicate by an association between
The cross-linking. So, any conclusion now? Because we need to move on.
No, this is ended. Usually this patient go see better after surgery. It is a fast procedure, a fast recovery time, and the patient were happy because the alternative of this surgery is
full transplant surgery, and this is certainly more conservative. And
is real surgery.
Yeah, absolutely. There are some patients where it will work really well. Well, thank you very much, and beautiful to see the surgery from remotely. So let's go back to Clinica San Nicola, where we have Professor Pedrotti. Emilio, ci sei? Emilio?
Perfetto.
Eccoci. Ciao Emilio, sono Vincenzo. Abbiamo visto il caso che presenti e dici un po', il paziente è già preparato, the patient is already ready, prepped, and so tell us, the way that you do the incision, what size graft you're planning, why you're planning that size, etc.
So,
Okay. Va bene.
good morning, everybody. I want to thank all the San Nicola's family to feel me like a home. There is a very organized live surgery for my cataract surgery about, I don't remember, 1 year ago, more or less. And with a Fuchs dystrophy, and now has a corneal edema. The periphery is not too bad, so I plan to put a graft of 8 millimeters.
Okay, and the view is really beautiful. Which microscope are you using there?
We use the Luxor by Alcon.
Okay, there's a fantastic view transmitted into the room here.
Un po' più su con il mento, signora, bravissima.
And the anesthesia is
a retrobulbar anesthesia with bupivacaine and mepivacaine. Is a mixture 2.5 millimeter for each anesthetic. Un po' di acido, no, va bene dopo. I perform the decimatoresis under visco in this case because the cornea is enough transparent to perform under the visco. I think is a more controlled maneuver. If I have a very cloudy cornea, I use air in order to facilitate the visualization during the semesteresis. I more or less measure 8 millimeter and 25 of decimeter axis, a little bit bigger than the graph. I can try not to push so much in order to avoid stromal damage. And now you say.
And which kind of price hooks are you using? This looks like it's got a funny, unusual curvature.
What kind of? Sorry, I can hear you.
Price hook. That's what the
Yes, it's a price hook. The hexagon that I use almost for the design surgery. Is a long time that I use this instrument. I like the shape because it allows me to move in the anterior chamber easily and to reach the endothelium easily to remove it. Ok, allora devo fare un altro accesso, abbiamo una doppia cannula di buratto, quindi faccio un altro accesso. The organization is totally perfect. In fact, the patient is sleeping, is very calm. Ok, posso avere la continua per favore?
So Emilio, excuse me, I am Jose from Barcelona. Just a quick question.
Hi Jose.
Hi Emilio. You do usually do just, I mean, a difference of about 0.25 or 0.5 between your donor and your host rexis?
Yes. Sorry, Jose.
If the difference between donor...
The size of the decimeter axis and the graft size?
Yes.
Yeah, I would like to perform a little bit bigger decimeter axis because it's more easy that the grafts remain attached the day after.
Okay, but so 0.25, 0.5 is enough for you?
0.25, yes, is enough.
Okay.
I tried to remove all the visco, mainly on the back of the cornea.
Presume that you have used cohesive, no? Standard cohesive?
Yes, of course. It's easily to remove. I put some acetylcholine in the eye in order to constrict the pupil, because sometimes when you inject the graft, you can put under the pupil. All right. Now enlarge a little bit the incision in order to facilitate the entry of the graft in the anterior chamber when putting the tissue.
Have you performed peripheral iridectomy preoperatively?
No, I don't perform a iridectomy, neither in the DSEC, neither in DMEC surgery, because we maintain the patients up to 2 hours after surgery in a supine position. Then we dilate the pupil, obviously, after the surgery. Then we check after 2 hours, is the bubble in the anterior chamber is a little bit smaller than the pupil. We are pretty sure that we don't have the risk to pupillary block. Me la tagli qua che sei un po' incasinato, per favore. Vai. So we don't perform any iridectomy in our patients. we use air instead of gas. Mi lavi un attimo, grazie. So we don't have a pupillary block. Almost if you perform the peripheral lidectomy. I don't like too much to perform an inferior lidectomy. In these cases, mi lavi un attimo c'è il sangue, grazie. Because obviously you have to perform the lidectomy in the inferior part of the pupil if you want to prevent the pupillary block when you have your air or gas in the anterior chamber. I prepare the stitches because I would like to close the system when I have the graft inside. Poi mi dai un po' da... un po' di camera. Grazie. And now we are ready to inject the graft. Okay. Is the graft in a closed system. We remove the anterior part, so we are ready. I like to remove the air and move the graft a little bit. Now I close the stitch. And then we try to open. Not too tight to induce astigmatism. Well, perfect. Vieni qui. Now I would like to work with a very shallow anterior chamber. Tip tap.
Aria.
Tap and we try to open. Storto?
Mm-hmm.
Yes, is it upside down? So we try to rotate it by injecting. This way is correct. Of the oculus, center the graft.
So I have a comment for the panel. Diego, you probably know this. What percentage of DMEX in Italy are preloaded now? Yeah, Diego.
Maybe close to 1/3. Yeah.
This is another difference between the US and Italy. So 80% of our DMEX are preloaded by the eye bank. 80%, 80, yeah, yeah.
It's growing, but still in some countries we have this advantage, but in many others still people need to prepare themselves from a cornea. So I'd say, Spain is probably one of those countries' advantages, as Italy, but many others.
Just to some hydratation of the port side with antibiotic, then the surgery is done. Thank you very much once
Emilio,
again.
thank you to you. You have made perfect maneuvers, even explaining how you have to manage the graft when you have upside down position. So thank you very much. All the audience here is happy, they are smiling. That means that you have done a wonderful surgery. Thank you.
Thank you very much, S.I.C.S.S.O. Thank you.
I think we've got a few minutes left. I don't know if there's any further comment about the surgery or if we want to go back to Professor Alessio because we cut him a little bit short. Sorry about that, but before Professor Alessio, Emilio's gone now, or is still there? So the interesting thing is about the PI, because in the panel, how many of you don't do a PI and don't dilate the patient after?
È pieno di pubblicazioni.
Well, usually some people, when they do a PI, they at least leave the pupil dilated to try to minimize the risk of pupil block. I don't know what the panel does in terms of PI or not PI.
In my institution, people do PIs.
Yes, in my institution we always do PI, apart from one surgeon that dilates the pupil, a very experienced surgeon. But we don't see the patient. We see the patient after 1-2 hours from surgery and then after 1 week with the PI on.
I don't do PI. And I dilate the pupil, and I do PI even the day before or 15 days before, because you can have some reaction in anterior chamber that can make you in trouble when you try to manage the graft.